And I'm a PGY3 in internal medicine at Mayo Clinic. And on behalf of doctors Gopal, Loeb, and Roy, I'll be talking about a 64-year-old male with new onset left chylothorax. So the case presentation involves a 64-year-old male with past medical history of Crohn's, chronic back pain, cirrhosis due to non-alcoholic steatohepatitis, who had a liver transplant in 2016 and subsequent TIPS procedure in 2018, with portal venous thrombosis on apixaban, who presented to the ED due to dyspnea for 2 days. He did have a functional graft without any evidence of rejection. He denied chest pain, abdominal pain, fevers, chills, productive cough, coryza, or unintentional weight loss. He also denied sick contacts or recent travel, and denied any other symptoms above baseline. His vital signs were significant only for a new oxygen requirement requiring 3 liters to maintain a saturation above 90%. On physical exam, he was oriented ×3, had a normal cardiovascular and abdominal exam, including no apparent ascites, and his respiratory exam was significant for the 3-liter nasal cannula requirement, with decreased air movement in the left base without Rales rhonchi or wheezes on the right side. So he had a chest x-ray on admission that showed a left pleural effusion, and it was compared to a chest x-ray as shown in figure 1A 1 month prior to admission that didn't show any evidence of pleural effusion. Thoracentesis was performed, which showed orange cloudy fluid with an LDH of 95, protein of 1.2, and triglycerides of 164, consistent with a transudative chylous effusion. And the cytology showed reactive mesothelial cells that was negative for malignancy. As mentioned, he didn't have any evidence of ascites on exam, and the abdominal ultrasound performed on admission corroborated this physical exam finding, showing no significant ascites that could be drained by paracentesis. He did have a CT chest done, shown in figure 1B, that was done 1 day after his initial thoracentesis, and he had no evidence of mass effect or solitary nodules, but did have a reaccumulation of the pleural effusion. So to review chyle and chylothorax, chylothorax is chyle in the pleural cavity. Roughly 2.5 liters of chyle is produced each day, and the location of a thoracic duct disruption ultimately leads to the location of where a pleural effusion may form, either on the right or left, depending on the level of injury. And the diagnosis of chylothorax can be made with pleural fluid triglycerides greater than 110, as demonstrated in our patient with triglycerides of 164. The consequences of chylothorax include respiratory failure, malnutrition, and mortality. As far as epidemiology goes, chylothorax is often neoplastic in origin, whether metastatic disease or primary lung disease. It could be iatrogenic from disruption via radiotherapy or surgery. There's also a variety of other causes, and many times it ends up being idiopathic. In the setting of liver transplant, there have been reported cases of chylous ascites, leading to translocation into the pleural space. However, this is proposed not to be the case in our patient because he didn't have any evidence of chylous ascites. So as far as treatment, the patient was initiated on a low-fat diet and required multiple thoracenteses due to reaccumulation. He did have a subsequent TIPS procedure revision and had resolution of dyspnea, and it slowed the reaccumulation of his chylothorax, which permitted his discharge with outpatient follow-up with pulmonology. So definitive treatment for chylothorax includes conservative measures such as treating the underlying medical disease, low-fat diet with an increase in medium-chain triglycerides, consideration of TPN initiation, octreotide or somatostatin, and then if those therapies don't work, proceeding to surgical intervention such as thoracic duct ligation or pleurodesis, or in the case of liver transplant, TIPS procedure, which has been shown to be effective if recurrent, without any contraindications to TIPS. So in conclusion, liver cirrhosis is a rare cause of transudative chylothorax. Chylothorax should be considered in patients with new onset unilateral chylothorax in the setting of cirrhosis or prior liver transplant. And we present the second reported case of an isolated chylothorax related to cirrhosis without chylous ascites. And finally, TIPS is an effective treatment for patients with chylothorax due to underlying portal hypertension in patients with cirrhosis or history of liver transplant. Thank you.